The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. Welcome back to the Virtual Curbside. This is our monthly episode 4, where we get to ask our speaker all the questions that we've gotten from our episodes for the month so far. And by the way, thanks for all your questions and feedback. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is the week where we get to ask questions, which is always kind of nice. We're so fortunate this month to have 3 of our guests back with us to deal with some questions that have come in. Welcome back, Sarah Winter, Kristi Glotzbach, and Laura Wood. Would you like to share your conflicts of interest with us?
I have none. I also have none.
I'm a consultant for Rialto Life Sciences and Tellers Therapeutics, but these don't have anything to do with the talk that we're doing tonight.
Terrific. Let's dive in. Question number 1, we'll direct this one to you, Sarah. How's that? How can PCPs build stronger relationships with specialty centers when they're practicing in rural or resource-limited areas? You described such a great program, but a fair number of our listeners, even in the state of Utah, are a little farther away. What can they do?
So there's a number of different avenues they can pursue. They can always directly call us through the physician line at Primary Children's. They can reach us and ask specific pointed questions about a particular patient. And then we have a variety of different learning opportunities. One is this virtual curbside, which of course I take advantage of all the time myself to learn about other disciplines and other knowledge areas. Then we have more involved learning that can go on in developing relationships. We have an autism echo that any provider can participate in, run by our Aspire team at the developmental assessment clinics. You could actually become an autism evaluator in your own practice, even if it's far away from us. And the echo is, of course, over Zoom link, so there's no travel involved. And then coming to various conferences, Primary Children's always puts on a really nice primary care pediatric conference in June. And it's there where you can meet a lot of your colleagues, the subspecialists. But again, a phone call is just fine as well, an email. We welcome any communication with primary care providers, and I have done that actually quite a bit. Then the most involved level is you could participate in the grant that I oversee, which is the Utah Regional LEND, which is Leadership, Education, and Neurodevelopmental Disabilities. And we've had a variety of pediatricians join us for an academic year, about 9 months of learning and getting to know us. And boy, would you network through that if you wanted to participate. And that, again, is all over Zoom, so no travel is required for that.
If somebody wanted to sign up for the Autism Echo, how do they go about doing that?
So they can contact our Aspire team through Primary Children's, and our main contact for that is ashley.stewart@hsc.utah.edu, and she'd be happy to get you the right information to get going on the Autism Echo.
Terrific. Ready for the next question? Kristi, you want to field this one?
Do you mind if I just add one more quick
Please do.
PCPs get plugged in? I think that we are certainly biased by the way that we do things here in Utah, but one thing that we've learned in our collaboration with other centers through the Cardiac Neurodevelopmental Outcomes Collaborative, there are a number of webinars as well as resources for primary care pediatricians on cardiacneuro.org. And through those collaborations, there's also the opportunity to connect with other providers across the country who may also have different resources and different systems that they work in to be kind of innovative and thoughtful about the way that PCPs engage with primary medical centers. So we certainly, as cardiologists and folks who are involved at the specialty level, find the Cardiac Neurodevelopmental Outcomes Collaborative a great resource, both for connection as well as kind of an understanding about best practice.
And you said that was cardiacneuro.org?
Indeed, cardiacneuro.org.
Excellent. What a great resource. And do you say that also there's some capacity for some sort of conversation there too?
Certainly, there are contacts for all the members within the Cardiac Neurodevelopmental Outcomes Collaborative on the website. And there is a webmaster and contact on the website if kind of needed contacts or to be able to take the opportunity to reach out to others through the administrators of the organization. Folks can reach out directly to other members. And there are webinars, and we're about to launch into our scientific sessions in the next couple of days here in Denver, Colorado, and that happens in the fall every year. And that is also populated by pediatricians as well as psychologists and a number of other subspecialty providers within the world of cardiac neurodevelopment. And it has kind of a spectrum of information. So if PCPs wanted to engage in the collaborative, that also might give them the opportunity for more learning about how to engage with the larger centers with the subspecialty cardiac neurodevelopmental programs.
That's great. Those are some great resources. Kristi, you want to deal with the next question? Question number 2. What role do prenatal factors such as maternal health and fetal environment play in long-term outcomes? Do we know?
I think we know a lot of things, as we've talked about in some of the episodes discussing kind of risk factors for neurodevelopmental challenges across the lifespan and congenital heart disease. Certainly prenatal factors fall into that category of risk. I really wish our partner, Whitney Hogan, was here. She's the director of the Fetal Center at the University of Utah, and she's an expert in this field. So I will borrow from some of her expertise, and I've learned a ton from her and other fetal cardiologists. But the maternal fetal environment certainly has been shown to have some impact on developmental outcomes. Maternal mental health has been studied as a potential impact and a target for improvement related to longer-term neurodevelopmental outcomes. Certainly, circulatory perturbations or circulatory abnormalities that result in decreased oxygen to the brain as well as nutrient supply, those factors are kind of unavoidable based on the anatomy and the physiology and the fetal environment, but that certainly comes into play as we see the kids that are born with congenital heart disease who have metabolic brain abnormalities as well as early neurologic injury, even before they go to the operating room for elective repair. I will say certainly other things that are related to kind of maternal health just in general, like environmental exposures and placental physiology also can play into and result in abnormal circulation to the brain. And I think those things kind of all coupled together are the things that we think about the most in terms of risk factors in the prenatal period.
Very helpful. The next question is sort of related in some ways to that, or at least I think you suggested some part of the answer here. But do neurodevelopmental risks differ between children who undergo surgery in infancy versus later? I think you alluded to that during the episodes, but would you mind just going to that a little bit more?
Absolutely. I think the majority of the data that we have currently in terms of kind of lesion risk factors are in our hypoplastic left heart syndrome population, as well as our transposition of the great arteries patient population. That's where the majority of the kind of historic and longer term neurodevelopmental outcomes are studied. And we do know that the neonatal brain is certainly more fragile than that of a more developed brain. And so we certainly think of those patients who require surgical intervention with cardiopulmonary bypass at highest risk if they undergo surgery at less than a year of age. And that is why the bulk of the recommendations are to get those patients in for neurodevelopmental follow-up early because they pose the highest risk. Certainly older patients above a year of age all the way through. I think the way we think about those patients are those kids who have kind of multiple hits, for lack of a better descriptor. So patients who have a surgery at 30 days of age or less than 30 days of age, patients who then have to come back at 6 months for another operation, those patients who then come back at a year or to follow up, and maybe even by the time they've had, get ready for kindergarten, they've already had 3 or 4 cardiopulmonary bypass surgeries. And so I think one thing to keep in mind is that not all patients with congenital heart disease are a one and done operation, for lack of a better descriptor, but our patients kind of have repetitive exposures to ICUs and the environmental and kind of medicalization during very vulnerable periods for brain development. And so it's not just the patients that we kind of have highlighted in the first year of life with their principal operation, but it's really the patients in general who have multiple operations that really seems to have a significant risk. And then not only is it the fetal period, not only is it the perioperative period, not only is it the intraoperative period, but they have looked at family health and social determinants of health and the impact on patients with congenital heart disease, posing even further risk as they move into school age and into high school and young adulthood that really do have a significant impact. So it would be really great if we had kind of a developmental scorecard where we could kind of check off the patients that we knew were going to be at the highest risk. And we as a community are really working to kind of isolate the highest risk populations and really risk stratify simply from a resource utilization standpoint. But overall, we do continue to be concerned even above a year of age. And there has not really been any specific literature to suggest that those risks can be isolated to a specific lesion type or a patient cohort.
And I suspect it's a delicate balance in every regard, trying to make sure that you do the surgery at the time that you need to support everything.
Absolutely. There are certain kind of persistent and hemodynamic and circulatory abnormalities that happen in these children that are a consequence of anatomic heart disease. And I think we talk about congenital heart disease and the surgeries required, not as corrective surgeries, but as palliative surgeries. And so I think that helps me more often to create a framework in my mind that the story is never completely told, even with kind of modified or intact circulation. I think the consistent concern about the implications of circulation, as well as kind of all the other medical care required, still continues to factor into our longitudinal care for neurodevelopment in these patients.
And as with almost every other population with neurodevelopmental concerns, early recognition, early intervention is absolutely necessary, which is your whole point.
Absolutely. I think we talk a lot about how much more common the developmental challenges are than they are severe. And the way that we talk to families about these challenges that they may come up against is that it's expected. And as long as we're surveilling and evaluating, both in the primary care setting as well as in cardiology clinics and in subspecialty neurodevelopment clinics, we're more likely to be able to put supports in place early in order to optimize the neurodevelopmental outcomes.
Very interesting, very helpful. Laura, you want to handle the next question?
Sure.
Here we go. Do you have any suggestions from your experience and practice for how we can support the whole family of a child with congenital heart disease at risk for neurodevelopmental delay?
Yes, that is definitely such an important question. I'm glad your listeners are thinking about the big picture. When a child in a family has a heart condition, the whole family lives with a heart condition. It isn't isolated just to that child. At different stages of a child's journey or a family's journey, this may look different for what these needs would be. And it may look different depending on the child's individual heart condition and what they expect to go through. I'll start with the parent because there is no child without a parent or without a family, a caregiver. And so a lot of our families nowadays are able to get a fetal diagnosis, which can help with planning, but it also puts some of that stress earlier on. It starts in pregnancy where parents are experiencing loss and grief before their child's even born. So starting in prenatal period, we talk to families about maternal and paternal family mental health services that are available. The Utah Maternal Mental Health website has a really awesome search engine that we suggest to families that they can help identify a therapist that can work with parents prenatally and through their kind of perinatal experience the first year of life. Oftentimes we talk about how it feels like a lot when you first receive the diagnosis, but it also in a way is the calm before the storm. And so the more supports we can put together and the more resources we can build the family's village with before the baby's born, then they'll already have some of that moving into when they're in the hospital and coping with that. For family members, Primary Children's has a peer mentor system, so they can actually be connected with other families who have similar diagnoses. We hear all the time from families that some of their biggest supports have come from either parents that they have met in the hospital or who they know through other ways that are going through similar experiences or have gone through similar experiences. They feel a lot of times more comfortable talking to them about questions that they may think the medical team thinks is a silly question. What can my baby wear? What can I bring to the hospital? How is this going to affect other things? So it gives them someone to really talk with. Utah Parent Center also has some resources for families to connect them. But it goes really beyond the parents and it goes to the whole family. So siblings, for any sibling who is getting a new baby brother or sister, you see that adjustment period. I'm sure pediatricians all the time hear about, I don't know what's happening to my toddler. We
Yeah.
are making good progress, like toileting regressions, sleep regressions, behaviors, clinginess, all that you see for any family. Those are really noticed even more so when you now have a baby who's in the hospital. Parents are more stressed. Parents aren't with their other child as much. There's separation from them. That adjustment period for siblings can be a lot. We do have child life specialists that work at Primary Children's Hospital that can help families talk to their other children about what's happening, can help them understand the medical equipment. What does this mean? And give families a voice and a way to describe things in child-friendly language. There are also some wonderful books. I don't know if there's a way we can share the book list that I often
Yes.
give out.
Yeah, we'll link to that.
Okay. There are books that describe like my brother needs an operation or my brother's in the NICU. There's also books that describe grief and loss in child terms. The truth of the matter is not all of babies with congenital heart disease will survive, and having words to describe to your child, either you're younger or you're older. So, if you have a child later on and you want to explain their brother to them, what words do you use to explain that if you've experienced that loss? So some awesome books. I'll try to get that book list to you so you can include it.
Well, that'd be great.
And then the fun side of it, there are fun sides of it too. So one thing I just wanted to highlight is there is a summer camp every year in Utah for children with congenital heart disease and their siblings. It can be an overnight camp or a day camp. It's called Camp Hawkins. I've heard such good feedback from families. It's a great way to connect with other people, other families going through similar journeys. So that's also a fun resource for families.
It's interesting because I think sometimes the way we talk about it, when I'm pointing myself here, trying to find the balance for the family between realism and hope. And I think that's a difficult balance to walk sometimes. I'm always reminded of a, bright, well-educated family who, as we'd been talking about neurodevelopmental delay for a while, they said, we were under the impression that delay just means everything arrives just later than usual. And I realized that I really hadn't given them the foundation they needed. And I think that learning to talk about that and drawing on the resources that you've been talking about is so helpful.
Yeah, it is. We get so used to the world we live in and the language we use. And so even if we are talking to families that have a lot of experience and are well-resourced, it's a different language for them still. They may have a lot of experience in other areas, but for most families, getting a diagnosis of CHD is a totally new world. It's a totally new vocabulary. So absolutely, I think we need to think about how we're wording it and really tying it back to like, what does this look like? What does this look like for the future and what supports are available? I always say that we can't predict outcomes, but we can put safety nets under every single outcome. And so the awareness of families of what those nets are, and because we can't predict what their child's going to be like sometimes, even
Right.
6 months from now, much less later on, but just knowing like these are the networks that are in place. So regardless of what path happens, we have these safety nets in place.
And, something you mentioned a minute ago, it's not uncommon that parents will see the other kids' behavior change. And, I'll be talking to them about this. So you don't understand, they love the baby a lot. And my response to that is, you can still be stressed and you can still see stressed behavior when things are different. Sometimes even joyful things make the kids act stressed. So
Yeah, definitely. It's an adjustment and everyone expresses their adjustment differently. Kids adjust it different. So for sure, it's a journey for everybody.
Sarah,
I
yes,
just think
yes,
that Laura does such a nice job of addressing the parents' mental health, not just the child and sibling adjustment, but we have lots of very anxious parents. And I was wondering if
with
you
good
could
cause.
just emphasize
Sure.
a little bit more about what you do in that scenario.
Laura, you want to talk about parental mental health a little bit?
Sure. Yeah. So we're fortunate in our clinic that we have a social worker who can screen for parental mental health and social needs. But even in situations where that's not available, I think we should go by the assumption that no matter what the reaction is, this has been a stressful experience. And for some, it's been traumatic experience. And so I think going under the assumption that even if the family is coping well, you can still have very typical reactions to a very atypical situation. And so making sure we are acknowledging it, asking about it, and providing those resources. For a family who has gotten a diagnosis of CHD, it's kind of like being in a lightning storm in a way and getting struck by lightning. You have this event that happened to you and it may never happen to you again. Your odds of it happening to you again may be the same as anyone else, but you're always going to look at the sky different because you know what can happen. And so I think it puts a new perspective into parents' lives. And so their baby's cry may mean something different to them than another parent who hasn't experienced this level of stress or trauma. Their baby's cry may mean something different to them than their older siblings' cry had meant to them. So we have a lot of parents who are dealing with them, nervousness, anxiousness, not being able to tease apart as much. Is this a normal baby thing, or is my baby experiencing shortness of breath? Is this crying normal, or are they in pain? It's harder to tease these things out when you've seen your baby in an ICU setting. So absolutely, we encourage in the pediatrician's office or in primary care to always be aware of that and have screening if possible. I know now a lot of times in those early perinatal visits, we have that screening. But the same way we want to take seriously little red flags or early signs of neurodevelopmental for the child, we kind of want to take some of that screening seriously for the parent too, because it can lead to this snowball effect of their anxiety becoming their child's anxiety one day, or kind of limiting their ability to be the parent they want to be. And so absolutely connecting to the resources. My favorite early resource is just talking to him about the maternal mental health website that I mentioned earlier.
It seems sometimes, too, that people experience emotions that they don't expect to experience, things like guilt and anger and, other ways of seeing grief. You would approach that the same way?
Yeah, absolutely. Any reaction is a valid reaction. This is something we don't get trained to experience. It just happens. And so some parents have coping skills built up from other experiences they've had, but others don't have that kind of resource bucket available to them. So acknowledging it and being aware of some of those factors is so important.
And Kristi, you had a comment too?
In our clinic, probably have some of the longer visits for people who are not actually doing developmental testing. But just as a comment, I think one of the things I find both in the ICU as well as in the clinic, and some of the longest and most productive and really revealing conversations I've had are simply by asking the easy question of, how are you doing? I think these parents spend so much time, as Laura alluded to, talking about their child, talking about their family, talking about the ownership of the medical challenges, but sometimes don't take the opportunity to check in with themselves. And so sometimes I find it so gratifying, or at least taking the opportunity to highlight the parents and just ask them how they're doing and just letting them share about themselves. And that doesn't take a screener. It doesn't take a website. It just takes that personal connection that most pediatricians have with their families. And it really is a way of honoring the work that these parents do in order to really help give their kids the best life possible.
Yeah, it's so personal. I think this has been very helpful. Thank you so much for taking the time, for one thing, to educate us this month, but to further educate us and respond to some questions tonight. Thank you very much, Kristi Glotzbach, Sarah Winter, and Laura Wood. Jory was unable to be with us tonight. Please give her our immense gratitude as well.
Thank you.
Having
Pleasure.
us.
All right. And to our listeners, we'll be back with another topic next week, and we will post those links and materials to the website. So please feel free to go there and look. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Paul Wirkus, who also composed the theme music. See you next time.